Hi, I'm Akanksha Sabapaty, and thank you for giving us this opportunity to present our study titled Comorbidities Do Not Affect the Pain Symptoms and Recurrence Rate in Patients with Pilonidal Disease. This study was performed under the supervision of Dr. Bill Chu. Pilonidal disease is an acquired inflammatory disease affecting the sacrococcygeal region. It's a rather disruptive disease characterized by chronic wound and draining sinuses. There are multiple predisposing factors for pilonidal disease, including thick skin, hairy body, a BMI of over 25, repeated chafing, deep gluteal cleft, and sitting for several hours a day. It has a high rate of recurrence, as high as 33%, which leads to long-term morbidity. So we wanted to evaluate the factors that may influence the pain symptoms and recurrence rate in patients with pilonidal disease. Diseases like diabetes and obesity can lead to increased inflammation and poor wound healing. Because of long-term morbidity, pilonidal disease can have an impact on the psychological well-being of adolescents, leading to anxiety, stress, and depression. There is evidence that anxiety and depression can delay wound healing. So we hypothesized that certain comorbidities can affect the pain symptoms and recurrence rate in patients with pilonidal disease. So we used a retrospective observational study method to assess our parameters. For each patient that came to the clinic, we recorded their comorbidities, pain score, recurrence rate, and the procedure that they underwent. Pain score was recorded based on a validated numerical scaling, and all the data were analyzed using multivariate t-tests and chi-square tests. Our standardized treatment protocol included the following steps. Patients came to us either as an initial encounter, after recurrent symptoms, or were referred to us. If the patient presented with an abscess, they underwent incision and drainage. Similarly, if they presented with pits, they underwent pit excision using the Gibbs procedure. This procedure has gained popularity due to its minimally invasive approach and lower recurrence rate. Since hair is the most common perpetrator in pilonidal disease, all patients underwent hair management regimen, which included shaving at home, supplemented by the laser hair removal. Laser epilation were performed every 6 to 8 weeks with the goal of achieving over 90% hair reduction. And regular laser treatments ensured timely follow-ups. We found that among the 207 patients in our cohort, there were 108 males and 99 females. The median follow-up period was 519 days, which is roughly about 1.5 years, and the recurrence rate was 7%. 55% of the patients presented with pain as their initial symptom, and 61 patients presented with comorbidities, out of which mood and psychiatric disorders predominated. We were more interested in diseases like diabetes and obesity, since they're characterized by poor wound healing and chronic inflammation. But much to our surprise, we found that they did not seem to influence the severity of symptoms and the recurrence rate. So while most of the comorbidities were overrepresented in our cohort, we were surprised to find that there was no association between comorbidities and recurrence of pilonidal disease. The pain score and duration were also not influenced by the presence of these comorbidities. So in conclusion, a pilonidal disease patient's comorbidities may cause surgeons to re-evaluate their management strategies. However, this finding encourages clinicians to adopt a standardized treatment protocol to achieve a low recurrence rate despite having comorbidities. This can also help us set expectations when counseling patients who have pilonidal disease with comorbidities. In the future, we would like to continue studying these patients over a longer period of time to observe the trends in the recurrence rate. Thank you.